Welcome back, and thank you for staying with KTN Prime. And of course, it's this particular moment that we get to have a sit down, a conversation with Dr. Deborah Barasa, the CS Health in this country. Good evening, and thank you so much for making time for us. It's good to have you back, actually.
Thank you, Ashley, for having me. Thank you.
Anytime, Karibu. So let's start with the recent issues that are happening in the country. Just yesterday, you signed a return to work formula with the clinical officers. Some good news there, ending that strike. But here we are again. Another strike looms as doctors and civil servants have threatened to take to the streets come March 18th. What are you doing to avert this?
Yes, you know, Ashley, dialogue is really critical. Open dialogue, listening and ensuring that you have interventions coming in as fast as possible.
Yeah.
And that is actually one of the lessons we've learned from the clinical officers. And so we are really engaging the teams, you know, the SGs and everyone to ensure that we are addressing their issues. So we are very happy with the clinical officers. Now they are offering services in the various healthcare facilities. And that is quite a big gain for us as a ministry, because we need the human resource for health when to serve the people of Kenya. So right now, even with the medical interns, we are engaging them, the civil servants, and what we want to tell them is we are working as fast as possible to ensure that we have a scheme, a medical scheme, that is the public officers medical scheme for the civil servants, and also addressing the medical interns grievances.
Okay, correct me if I'm wrong. The Public Officers Medical Fund was established in 2012 when the civil servants forfeited their medical allowance for insurance scheme. Like many are saying, they're contributing double for SHA and for the fund. Why is that?
Now, for SHA, what SHA is about universal health coverage. It is like the bare minimum that each one of us needs to have. Suppose you lose your job here, Ashley, what are you going to use? SHA will be there for you. So it's a universal health coverage. And you can see from the benefit package, there's quite an enhanced benefit package when you compare to NHIF. And really, this is what, as a country, we need to focus on and move forward to ensure that SHA works. Because when SHA works, then our health insurance as a country is going to be good. Any one of us can access the care, that universal health coverage, you see. So what we are encouraging Kenyans, let us all register. When we all register, when we all contribute, then there is no need even to have those parallel or fragmented medical schemes. So yes, we are working on the public officers medical scheme, but what we are saying that critical to us, all of us, whether you're rich, whether you're poor, you know, you have a job or you don't have a job, you know, whatever kind of background you're coming from, SHA and Taifa Care is what will work for all of us. And really the message is that let us all register and contribute so that we can be able to access care.
So then, is there a timeline in ironing out these issues? Because next week is just a few days away.
Yes, yes, we are working towards that. And what we have done, we've allocated some resources to support the scheme. So you know, for the police officers, they were under another scheme. That was the private practitioners medical administrator. That was the medical administrators Kenya Limited scheme, which is by a private practitioner. They were not under NHIF for a whole 2 years. And now what we are telling them, they need to register for SHA. If they register for SHA, they can access healthcare services like any other Kenyan. Then after that, then there's the top-up from their medical scheme that they have. So ultimately, SHA is the way to go. We are talking about medical students or interns out there who don't have a job. They can be able to access this very same care. And I remember myself being an intern. I remember being, you know, a postgraduate student. You could offer the services, but the very services that you're offering, you can't afford.
Okay.
Yes.
And we'll talk about SHA in length, but you know, the unions are claiming that the move to deny public servants medical cover is a deliberate effort to undermine the workers' welfare. Is this the case? Because then, where is their money going?
Absolutely not. That is not the case. We are working towards it, and you know, these are actually maybe we will have the public servants, the group coming here to discuss that. But as a ministry, we are supporting them to have a medical scheme. But you know, the thing is, Kenyans are not getting. Social Health Authority is universal health coverage. It is for all of us. Whether you have a job or you don't have a job, it's for all of us. So why not have the bare minimum, which is SHA?
CS, allow me to interject. Their issue here is that they are having double deductions and they're not getting value for their money. So it's not even about SHA, it's about value for your money when it comes to healthcare services.
Yes, so what I'm telling you is that we are working towards having the medical scheme. We have been able to allocate resources. Yeah, the public service has been able to allocate resources, and we have a scheme. They are working. Yes.
All right, so let's now talk about SHA. So majority of Kenyans claim that SHA is not working for them. The government insists SHA is working. From where you sit as the CS, if SHA is working, what exactly is working in SHA for you?
All right. Now I'll start from NHIF. When you look at NHIF, there was accrual of debt for many years, and actually they were anticipating that it would crash in 2022. So we were going nowhere. It was actually plummeting, and the debt had accrued to 30 billion, okay? So now NHIF was really not the way to go, and everyone knew it, but no one was out to call it. Secondly, when you look at NHIF, the administrative costs were at 37%, yeah. So meaning the contribution of Kenyans, 37% of it went for administration, and then the rest would go for service to the people. When you look at SHA, only 5%. So meaning there's more money for health service delivery for Kenyans. Another thing is the false claims, okay? So what we saw in NHIF, there were multiple false claims. I can give an example of a leg being amputated 5 times, you see? Or a mother delivering 50 times in a year. So there were a lot of false claims that were coming up, yeah? And again, that one was a way of corruption. And what we are doing for SHA is that we are ensuring that we have a digital platform. And in this digital platform, we continue to enhance it so that these inefficiencies, this corruption that was occurring, we are able to address exhaustively. And one of the ways you can see is transparency and accountability. When you look at the site, you are able to see that we have printed all the facilities, how much they've been able to receive up till now, okay? So if anyone has a concern, then they can raise their grievance. There's a link where you can click and you're able to see what are the concerns, yeah? Because what we noticed is some private facilities, okay, were complaining that they have not received any money, but yet there were errors. There were errors in terms of the name of the facility or the account, okay? So what we are saying is that it is open. In fact, right now, when you listen to private facilities, they are concerned. They're like, now when you're exposing us of how much we've paid, people will start asking for raise, you know? And thirdly, when you look at NHIF, it had multiple schemes. Now, for the multiple schemes, you will notice that for the civil servants, they were getting a better deal, okay? So they could travel, abroad for services, etc., at the expense of the ordinary Kenyan, whose amount was limited, right? And in some private facilities, it could only pay for a bed. Now, when you look again at SHA, you see that there's enhanced health package. We have now mental health, we have oncology services, and we have dialysis services that have been expanded. We have critical care services like ICU, which was not there under NHIF. So there's enhanced package. Again, the vendors who are causing corruption and digitization is helping. And again, fictitious facilities. There were some facilities which were non-existent. There was a one-roomed facility that would claim for ICU beds of 50, okay, or that could claim for dialysis, And a critical thing that I need to talk about is the primary health care. In this kind of a scheme, what we are strengthening is the primary health care facilities. Why is that? long time ago, you remember, okay, maybe you were not born, but we used to go.
Not as young as you think, but okay.
So we used to go to health centers and dispensaries, and medicine was there.
Yeah.
But right now, what's the norm? Everyone assumes that the health centers, dispensaries have nothing. Everyone has now, flooded the level 5 and level 6. What we want to do is to revive the primary healthcare facilities. Yesterday, when we were with the meeting with the Council of Governors on USG funding, I remember, Honorable Waiguru was looking and saying, oh my goodness, you mean my health center has gotten all this money? Why should it get all this money? I expect this to be at the higher levels of care.
Okay.
But what we are saying, we want to capacitate the primary health care so that right at the door, close to your home, close to your neighbor, you should be able to access those very services. And then now for level 5 and 6, those are the referral, the patients who have complicated. Okay. And again, capacitating the public facilities so that we can improve the services for all patients.
Allow me to just recap so that I'm sure that I got you right. You said NHIF went down because there were 30 billion shillings in debt, right?
Yes.
Here we are, we have spent 104.8 billion shillings on a system. You claim that the multiple schemes were in NHIF, and here we have enhanced health packages on SHA. Why not? Because if you're using 104.8 billion, yet on this other hand, you had 30 billion, the math is not making sense. If there were all these schemes and all these issues, why not streamline rather than come up with a new scheme altogether?
Okay. So first of all, you should understand that NHIF scheme was corrupted, all right? So there were people who could be able to hack in and make some crazy, transactions or remove money from the system, all right? So it was not stable. It had people who had learned and understood the system. And you can talk to a few doctors and you'll really listen and understand what they are saying. Because what someone would have to do, a healthcare worker, is just, talk to someone who's inside the NHIF and tell them, or maybe the one who's inside is saying, let me send you 200 million, give me my 20 million, and then try and figure out the account.
So why not clean up the mess then?
And so, when you look at this system, it is the digital health superhighway. It has multiple components with the health information exchange system. One of them being the the patient portal that will look at the patient journey. Once the patient enters the room, once they take their vitals, you can always have a chart of their vitals, and again you will have the examination, what medications they've been given, and then the claim goes to social health authority. So you can see the patient's journey, and this is historical, you see, and then you can use the same, it's interoperable, so you can use it in any facility, in any county, so you don't need to carry all those things. Secondly, it has the health workers register. So we need to ensure that all health workers are licensed, okay? Mm-hmm. So that improves quality. Again, it has medications, okay? And again, the healthcare facilities, ensuring that each one of them has been assessed, okay? And, and is capacitated on that level of care, okay. All right? And again, it has the ICHIS, which is the, community health information system, all integrated. Again, surveillance, at times you may have an outbreak. How fast can you pick it? You can have, right now there was recently a diarrheal disease in Kisii. We need to pick these things promptly as
I
public
don't know,
health
CS,
experts.
once again, if I may cut you short.
Yes.
Have you interacted, perhaps you were not feeling well just the other day, last week. Did you interact with this SHA? Did you experience the delays that, normal Kenyans do experience?
Yes, and let me tell you something, Ashley. Delays can occur. Even when you look at the systems, the finest systems in UK and US, yourself, even when you have your mobile banking, there's some delay.
But this
there's
is
some
your
internet.
life you're talking about.
And so what we are saying, if the system is not working, we're not saying health service provision is stopped because of a system. No, not at all. You can use hard copies. You can also have, the information out there, and then you can put it in once the system is up. Mm-hmm. So we are saying no Kenyan should be denied health services because of a system. But this system must work. You know why? Because once the system works, then we'll be able to avert corruption in the country. And seeing that it was a nationwide, rollout, and again, seeing that the systems, again, as I said, you can have interruption. And it's not unique. Even for systems that have been there for many years, there's a time when they tell you, please, you know, wait for a few hours, we are going to configure, we are going to work on it, etc. Because you need to build it up.
Okay.
Yes.
I want us to listen to Honorable Mutula Kilonzo Jr. Yesterday you were in a meeting,
yes,
and this is exactly what he had to say. Let's just listen in.
Allow me to say this, Waziri, in your presence, and if I don't say this, I won't sleep well at night. Kenyans are suffering. SHA is not working. Kenyans are complaining. So to Moses Kuria, when you write your advice, just say, from me, that Kenyans are unhappy. Very unhappy about these medical schemes. They are not working as they should.
This is yesterday. You were in that particular meeting.
Absolutely, yes, I was.
For Kenyans, it seems that for the government, it seems aloof to the problems that Kenyans are facing. Here we are, this is the 6th month down the line. It's no longer teething problems. These are problems that are affecting Kenyans who are seeking health services. It seems that the government is hell-bent on saying that a system is working, yet Kenyans are saying it's not working.
Okay. Now, you know, when after Mutula talked like that, I went and sat next to him and I asked him, have you seen the digital platform? Have you seen the dashboard? And he said, okay, this is my phone. Please set it up for me. And so I called one of the CEO for Digital Health Authority, and he was able to set up. Now, the governor saw that his county, Makueni County, had actually received 749 million Kenyan shillings. And he was perturbed. He was like, what do you mean? You mean I've been receiving all this money and I don't know? Now, what we are asking, if he's been able to receive this money and he is not informed, suppose he registers patients. What does that mean? That money is not remaining at national level. It's trickling down to your county, to your facility. And what you require is just to register and see patients under SHA. So if he is not aware of what his county has, suppose he becomes a SHA champion, that means more resources at county level, more human resource, more health products, more commodities, more equipment, CT scan, etc. And now you become a specialized facility, and you're able to see all these cases seamlessly.
How many now people what we are have saying, registered for SHA?
We've had, when you look at NHIF first, it's 8 million. Now under SHA, we have more than 20 million Kenyans.
How many people are actively contributing?
Okay, now I will answer. That's a brilliant question. First of all, you have to see that there is accessibility in terms of, number one, the numbers. Number two, facilities have expanded. Number three, geographical expansion. All the counties, unlike NHIF, which had selected, and it was actually private facilities that were benefiting.
You're still not answering my question.
Let me now answer your question. Now, when you look at those that have registered under SHA, there are over 20 million, right? Meaning they can access primary health care under the primary health care fund, which is from the exchequer, that is from National Treasury, meaning all Kenyans can access this. Among those 20 million, 4.4 million Kenyans have contributed, and they are able to access the Social Health Insurance Fund. So now, let me answer about your sustainability. When you look at, I said number one, NHIF had accrued a lot of debt up to 30 billion Kenyan shillings. Now, come to SHA. When you look at SHA, what we have, people have, the 4.4 million Kenyans have contributed 6.7 billion Kenyan shillings. The claims are worth 4 billion Kenyan shillings, meaning we have a surplus of 2.7 billion Kenyan shillings of the 4.4 million. How much more when we have all Kenyans on board?
But the system relies heavily on member contribution, right?
The Social Health Insurance Fund, yes. But right now, we are not facing any crisis. We have a surplus of 2.7 billion Kenyan shillings, meaning if all Kenyans are on board, then we'll be able to change our health system. And we will not be dependent on USG for funding and other things. We need to be self-reliant.
Yes. All right.
We need to be self-reliant. Yes.
So then, from everything that we have canvassed right now up until this point,
yes,
are Kenyans justified about being disgruntled on this particular system? Because you can have a brilliant system, you can have money, you can have contribution, but if services are not reaching to the common mwananchi, what's...
Services are reaching, we have not interrupted in, you cannot interrupt services because of a system, really. A system is a system. Services continue. The doctor is there, the nurse is there, they see the patient, and services continue.
Okay.
We cannot deny services because someone has not received their OTP. But what I'm saying, the system has the minimum viable product. That was what they had promised us at the beginning of the few months. Now they are expanding it. So I am confident because the system has been implemented in other countries with great success.
Okay.
Okay, so following the same pattern that we are using. And so we are confident. This is the way to go. All the countries are going. Everyone is talking about UHC. Yeah, and I think the donor fund, the USG funding withdrawal was an eye-opener for us. Do you know what we need to do, Ashley? We just need to plug in the HIV program into the broader health system. That is the UHC. What does that mean? We take our primary health care fund and incorporate funds for commodities for HIV, for malaria, for TB, etc. And then patients contribute under the social health insurance fund when they are complicated, you see?
Okay.
So it's really just plug and play for all these health programs that we have in Kenya. Okay. So ultimately, it's just one system that should work.
All right, the Auditor General's report did unearth a number of irregularities when it comes to that digitization system. So my first question then is, do we have control over that system?
Yes, actually we had this discussion, and what I told you in matters accounting, what I can assure you, we'll have a comprehensive discussion next Thursday. I'm going to call my PS, Medical Services, so that he can give you response for all the questions that you have on the Auditor General, because he had a comprehensive report. There were deliberations as well done within the ministry, and he should be able to answer those.
But at the end of the day, you are the authority in the Ministry of Health. You should be able to answer these questions, even as we wait for that comprehensive report.
Yes.
So then, do we own that system?
Ashley,
do we have control over it?
Yes, we have control. We are able to review the system. We are working together and collaborating to ensure that the system is functioning to the last mile. Yes.
Let me just quote the Auditor General's response towards that. Unfavorable contract clauses. For instance, the contract says the government cannot access or control the system. I quote, the procuring entity shall ensure neither the procuring entity nor the government health agencies nor the procuring entity authorized users shall access all or any part of the system to build a product or service which competes with the system or undertake similar functionalities to the system.
So for the system, what I believe and what I know, when we have any concerns with the system, we are taking charge. We are addressing all the concerns that the system has, and we are ensuring that they have been incorporated, including the issues of corruption and ensuring transparency. And what I'm assuring you, Ashley, let us have the PS Medical Service address all the questions that have been there with the AG and have a comprehensive discussion about that.
Okay. I want us to take a short commercial break, but we'll be back shortly.